Screen?
Yes, you can kick it off.
Okay, great. Great. So again, thank you for the invitation. It's a great pleasure. I'm going to be starting with our experience, early experience actually, in the intrasaccular devices. It's mainly one that's FDA approved, which is the web device. Those are my disclosures, but the most important disclosure is that I know this guy. He was at Jefferson for a year, and then we became friends, and then we enjoy same things outside neurosurgery. Yet I'm still convincing him about wine. He doesn't want to try actually. So as you know, uh, the evolution in everything in life and in devices for endovascular treatment of brain aneurysms, even Homer evolved. From clipping to coiling to liquid embolic to flow diversion to intrasaccular devices, it's a never-ending story. And again, things we used to do years ago that becomes now obsolete. Maybe the things we do today, when we look back in 5 years, it's going to become also the same thing. So this brings us to the notion of disruptive innovation in neurovascular disease. So disruptive innovation is actually a term that was described by a Harvard Business School professor, which is the process by which a product emerges into an existing market, typically from outside established market leaders, and then relentlessly displaces established competitors. So, and this is what we see every day in our world, in the neurovascular world. And it's very important to be able to survive, to stay open-minded, and to be able to embrace new technology, and to be able to look at it in a way that see the positive and the negative aspects, not to be really biased toward one way or the other. So what I'm talking about today is the web device, which is this cage that you deploy in the aneurysm. This is the old version, the double layer. Now it's only one single layer. But as you see, as compared to the old, how we used to treat aneurysms with coils, this is different. You go in with a microcatheter, you deploy the web device, and that's it. You're done. This is the trial, the WEBIT trial. We were part of it, that led to the FDA approval of WEB. This was a rigorous trial. The PI was Adam Arthur from Memphis. And so the WEB trial showed that you have adequate occlusion in 84.6% at 1 year. And here, what we're saying, adequate occlusion, is lumping all those. When we look at intrasaccular devices, we need to change our mindset from how we used to classify complete occlusion of aneurysms. If we say that this is, complete occlusion, if you take this neck remnant here, and if you lump all those, this is, I think, reasonably we can say this is adequate occlusion. And we all know that in general, we don't see aneurysms rupturing for neck remnants like that, and that this is acceptable. So in this trial, the retreatment rate within 12 months was 5.6%, where those were treated either with coiling or stent-assisted coiling or flow diversion. Overall, the retreatment rate was 9.8%. This is from my WEBIT trial. So 5 years ago, when the trial, we were part of the trial, and those are the results of the patients I enrolled in the trial. So this is an MCA aneurysm here. That's the web device, and this is the 6 months follow-up. This is another ACOM aneurysm, and this is the follow-up here. An MCA aneurysm, you see it here before and after on 3D. Another large MCA aneurysm that we treated in the trial, and you see here before and after. Another MCA aneurysm, same thing, before and after. A basilar tip aneurysm, as you see here. Another basilar tip aneurysm treated in the web trial. You see small remnant here that I've been following for 5 years now. And then this is a device where you can do a follow-up angiogram. It doesn't give you artifacts, and you can actually follow them with MRA also. So the advantage in those cases, so those cases that treated with a web device were going to be either a clipping cases or a Y stenting cases, because those are bifurcating aneurysms with a wide neck, where initially, if we wanted to treat those endovascularly, we have to place Y stenting and put the patient on dual antiplatelet therapy, or clip the patients, as you see here, or balloon assisted. As you see here, with those devices, we're able to treat those patients without the other techniques I talked about. So there are two shapes of the web. One is a cylindric shape. One is like a more a spherical shape, so the SL and the SLS. And those are the sizes of the web. So the first number is the width and then the depth of the web. And those devices are being delivered through 3 different microcatheters, the 21, 27, and 33. In Europe, we have the 17. Unfortunately, we don't have the 17 here. So this is from our initial paper that's under review now. We have now actually around 90 cases of webs. And as you see, the way the sizing is key. And what you're trying to do is you need to make sure on those aneurysms that there's no flow going between the wall of the aneurysm and the web. And the most of the flow diversion you'll have here at the bottom of the web, at the lower pole, not at the belly. And the way you size it is you take the biggest width of the aneurysm, you add to it 1 or 2 millimeters because you want it to be snug, you want it to oversize it. Once you oversize it, it's gonna elongate. That's why you're gonna subtract from the length of the web. And this is how you have one that's really where the web is pushing on the sides of the aneurysm. If you respect this, you will have good occlusion rate. Another technique here, which is corking the neck of the aneurysm. If you have an aneurysm with different lobes and irregular shape, you forget about this part and you need to size according to this part. And as long as you block the inflow, you will be good. If you see here, when you oversize a web device, it's gonna be tough to compress it. This is an oversized web. 9x5 as opposed to 8x6 here. If you don't oversize it, at that time you'll be able to compress it. When you put weight on it, it means you're gonna have a recurrence. As here, when you oversize it, it's gonna be tough to compress it. Support, I recommend initially to use a big support triaxial system. When I proctor for web, I recommend that in the initial cases because you don't have to worry about the support. You have to worry about your web device. So this is one variable put aside. So this is a case I show you a off-label PCOM aneurysm. So you see my device here getting deployed, and then it's bulging in the parent vessel. So what I did is I pushed it a little bit more. Once the device is open, it's soft here. When it's not open, you need to be careful. And then this is the detachment. And then this is the stasis of contrast. And you see the PCOM vessel is still open. And this is the follow-up angiogram showing that the aneurysm is gone. And there's some neck here, but that's also the inflow of the PCOM. This is a case of a ruptured aneurysm, very tough patient, couldn't do transradial, couldn't do transfemoral. In this case, I did a carotid cut down, and the patient had 2 aneurysms. So actually, I didn't do a carotid cut down, I did percutaneous. So I did a percutaneous carotid stick. The patient had 2 aneurysms that I was able to treat. One of them I coiled it, the other one I webbed it. So you see here, that's the PCOM. I called the PCOM. And then that's the other aneurysm. You see I'm deploying a web in it. Here's the stasis. And then I did an angioseal device on the sheath at the neck. This patient got heparin, so it's tough to do compression at the neck and it's not safe. So that's the angioseal device. This is an ACOM aneurysm where we decided to do web. As you know, it's a shallow aneurysm, shallow and wide. And this is a salvage technique where the web is occluding one of the vessels. It's easy to go in and place a stent and open the vessel. So what happened here is we deployed the web, and we see after we detach it that there's stasis of contrast in the A2. What we did is we deployed an Atlas stent. Here it is. The stent is getting deployed, and you have immediate patency of the A2, and you see the aneurysm is completely thrombosed. Sometimes it's a little bit worrisome when you see an aneurysm completely thrombosing acutely. We know that in the web device, you'll have stasis and then the aneurysm will disappear, like in flow diversion. Sometimes complete acute occlusion right away is a little bit worrisome. So as you see here, that's the web device and that's the stent. So this is a salvage technique with the stenting. This is a case of a recurrence of an ACOM where we decided that we're going to try to treat the recurrence with web. What's good here in the web device, it's one of the few devices where it would mimic the effect before detachment. When you coil aneurysms, you're going to detach the coils, look, and keep on coiling. You cannot. When you do a flow diversion, you need to detach it completely to see the effect. In the web device, you place the web. This will mimic exactly how it's going to look like, and then you decide if you're going to detach it. So we didn't detach it, we deployed it, and then we didn't see the A2 here, so we resheathed it and we removed it, and this patient ended up getting clipped. This is another case of an MCA aneurysm. Here it is, and very tortuous, transradial, and I'm going to show you here. So one of the challenges with the web device is you need to center your microcatheter. If your microcatheter, especially because those are relatively big microcatheter, if they are not centered, you need to deploy really and unsheath the web all the way to be able to have for the web to open. So as you see here, I'm in the aneurysm. I keep on unsheathing. I'm going to unsheath all the way. It still didn't open. This is because of the vector forces that I'm not centered, but there's nothing I can do other than unsheathing all the way. And here it is. Suddenly it opened up, and then you can deploy it. And here it is. It took the shape of the aneurysm. And then I'm going to detach it. As you see here, take a look at this junction. Suddenly it's going to flip. It means it's detached. So that's the junction. Here it is, it's detached. And this is the contrast stasis that you see in the aneurysm after detachment. As you see here, it's respecting the takeoff of the M2s. Be careful when you're pushing the device because the catheter may move. This is a basilar tip aneurysm. Unsheathing the device, and here it is. I can see the edges of the device, and this is the run showing complete stasis of contrast with nicely filling of the PCAs. This is an expert CT showing whenever you have any suspicion, you need to do an expert CT to take a look at the relationship of the web and the PCA, which is okay here. This is another unusual bilobed, one pointing up, one pointing down, ACOM aneurysm. I went up, did one web in each. So as you see here, I'm coming in with a microcatheter and parking my microcatheter there. This is a case also where the microcatheter is not centered. That's why you need to unsheath all the way, and you need to reposition after the web is open because it's stiff before it opens up. You need to be careful of the tip not to puncture the dome of the aneurysm. And here it is, it's deployed. Those are the two webs that are deployed. You see in an expert CT, one up, one down. Here it is. This is the immediate run. I'll show you the follow-up later on. This is another case of a web device. What happened is that after I detached, the web device flipped. It can happen when you have a vector force here. If you look at the microcatheter, if you have too much forward pressure, it's going to flip your web because the vector pressure, the vector force is not straight forward. And as you see here, here's the run. And you need to be careful that before you detach that you are at a neutral position. That's also key. So here it is. After I detached, what happened? The web flipped completely, but it's still there. And then on follow-up angiogram, it showed that it was gone. This is a ruptured ACOM aneurysm. This was actually around Easter time, and this looked like an Easter peep. So here, this was one of my social media posting of this aneurysm. So it actually looks like an Easter peep. And here it is. I'm coming up with the web device in this aneurysm. And here it is completely occluded on follow-up. Another case of a ruptured aneurysm. It's left-sided transradial. You're going to see a lot of those crossing transradial in my cases. Be careful, again, once you're coming at the ICA bifurcation, you may pull the microcatheter. So you need to have some forward pressure on it. And here it is, I'm deploying my web device. And once it flares up, it becomes soft, as I said, and you can give it a push forward and do a run. And here it is, it's detached. And this is the stasis of contrast in the aneurysm. This is one of the technical notes where we place the web device through the Snuffbox. This is the pericallosal aneurysm treated with web. You see here, I'm crossing, and that's the web device coming up, being deployed. That's the stasis of contrast. A carotid ophthalmic aneurysm treated with web. You see this, it's already almost occluded. This is also off-label. And then we've published on diverse use of web device with coiling, with stent coiling, etc. If the aneurysm is too big, you can coil and then place the web. So those are some pre and post basilar tip here. That's the one I showed you earlier and the most recent follow-up. This is a PCOM aneurysm before and after. This is an MCA aneurysm. This is the case I showed you earlier. That's the follow-up. Another case. That's the case earlier. And then this is our most recent paper published in neurosurgery about web in ruptured aneurysms, where we treated aneurysms, 9 aneurysms that are ruptured with web. We had no re-rupture of the aneurysm. This is a live picture of a web. This is a patient that had ruptured aneurysm, had multiple aneurysms. There, they treated the first one with a web, then the other ones couldn't treat it, so I had to take the patient to clip the rest of the aneurysm. On my way in, I took a sneak peek on this web. This is how it looks like in vivo, but the aneurysm was completely occluded. Off-label use with web, we've published that. We've showed you a lot of off-label. Again, I turn it into wine, and this is what we're doing here, corking the aneurysm. So I'm going to show you something. Yeah, which is corking the neck. If you have an aneurysm that's oblong, you don't have to go fill the whole aneurysm. If you place your web here and it's very snug, it will take care of it. This is a case of corking the neck. As you see here, it's deployed. And then we're going to pull it down a little bit to cork the neck. I'm pulling it down, and then I'll show you. And here it is, complete occlusion, and the aneurysm is bigger than that, but I corked the neck with it. And this is the run showing that it's occluded acutely with that. This is another one that I corked the neck, this basilar tip. Same thing. So you see here on expert CT, that's the web device, stasis of contrast above that. Non-occlusions, we had some where the aneurysm, there was no filling beyond the web, but there was still stasis inside the web. Again, we know from our European friends, they are following those. Again, it's still too early. We don't know what to do with those, but this is, for example, another case where it's still filling just the web, nothing outside the web, it's stasis. What we're doing is we're watching those, repeating an angiogram in 6 months to see what we're gonna do. Some other follow-ups here that we just had, basilar tip, MCA aneurysms, as you see here, the PCOM, another MCA. So it's a match between you and the device, not just the web, but any device you work with. It's exactly like dating. You need to get to know each other, you and your date, and you and your device. You get to anticipate the reaction to your action. You get to learn to avoid embarrassing situations. You get to know how much to ask and what to expect. Expectations is everything in relationships. and in devices. Avoid pushing to a nervous breakdown. And again, some wounds are not repairable. Be careful with that. In general, follow the rules. I mean, this guy is breaking every single rule, you know, no smoking, he's smoking, no wine, he's drinking, etc. And some challenges, as I said, the 21 microcatheter is the smallest one we have in the US. In Europe, they have 17. They have also smaller than 4x3. In the US, the smallest is 4x3. Long-term follow-up, we still need long-term follow-up. At this point, we don't have much. While the device is not open, it's very stiff, so be careful. Be careful with building up tension with the microcatheter. And it's taking away clipping experience from residency program. I train residents, and I need to keep in my mind that all those cases, I would have clipped them. So we need to keep this in mind. And the cost, of course. So it's a promising device. As I said, you're avoiding putting hardware in the parent vessel, so no need for dual antiplatelet therapy. Patients not candidate for clipping, it's a good option. It's adequate occlusion rates, if durable, would mimic the final result before detachment. Less fluoro time instead of putting too many coils. Here you do it and that's it. Avoid using balloons. And again, it's important to be open-minded. It's a tailored procedure for the patients. And remember, dinosaurs disappeared because they couldn't adapt to new conditions. Thank you.
You're very welcome. You guys can ask questions anytime, obviously. And I have a couple for Pascal as we're transitioning. If you want to maybe stop sharing yours. Actually, I'm going to share mine. Actually, you don't have to. I'm going to share mine. Pascal, a couple of questions. Great lecture. And very informative for all of us doing what we're doing here on the field. I saw a couple of the cases you did where, you know, normally we would think of flow diversion right away, right? A PCOM aneurysm and ophthalmic. How do you think it stacks up against flow diversion using the web device?
So those are some of the off-labels we've used. And again, we've done this because we didn't want to use dual antiplatelet therapy. As you know, with flow diversion, you have to do that. I think at this point, I think for those kind of aneurysms, I think flow diversion is still a better option. But in those cases where ruptured aneurysms or cases where there's a contraindication for dual antiplatelet therapy, web device, I think, works well in those cases. Again, we have more follow-up with flow diversion because it's an older technology. And I think at this point, nothing beats the durability of flow diversion. I don't think there's such a good durability with web, but only time will tell.
Perfect. And obviously, web does not need antiplatelet medications, right? You don't put them on anything like oil?
I start them on aspirin when it's a case that it's an elective case, but in 90% of the time I stop it right away after the procedure. Gotcha. And then if I need to stent acutely, I give IV2B3A inhibitors. Okay. In ruptured aneurysms, I don't give anything. I use the web without that.
And you said earlier about MRI interference. So, you know, from that perspective, you said maybe, is it less than coils when it comes to doing MRIs and stuff?
From what I saw, is less than coils, and it's a nice, you can follow up with MRAs.
Got it. But, you know, and probably, you know, the neck, I enjoyed what you said about the neck aspect, because, you know, this little tenting in the neck, that probably means nothing in terms of the possibility of an aneurysm being significant, right? Because you have a web, you have a clot above it, probably not high risk of rupture, I would think.
Yeah, again, I mean, we know that from our European colleagues. You know, here, I mean, we always like try to treat occurrences, and we are aggressive treating the necks. But we have a lot of patients from Europe that they followed those necks, and they have more experience with web than us. And those necks, majority didn't need anything.
Yeah, yeah, perfect. And guys, you can interrupt me anytime. We're monitoring the Q&A section, and we can ask any questions. So I'm going to move on to my side of treating aneurysms, and I'm going to talk a little bit about Surpass. Surpass is another device like Web became on the market, I think, around the same time in the United States. It's been around in Europe for quite a lot longer and a lot more experience there. But I think some recent changes and maybe in Europe there's been some challenges with adopting Surpass, but some changes, I think, mainly made by Alex Kuhn And AJ Wackley and the delivery of the system actually made it a lot more appealing for us in the United States. And it was around when flow diversion started, but it took a while to get approved. And so there's some differences in comparison to other devices that are out there. I just want to show you where I think it's a great tool and what are the challenges and technical pitfalls that we have. These are my disclosures. Oh, let me see, there's a little question here. Right. So I'll talk about the challenges in a second. So the goals in this presentation are obviously to describe the tips and tricks that we have in the deployment of this device, identify the benefits of the Surpass over other options and where it's lacking, and then discuss the failures, my failures and where I've learned, like Pascal spoke a little bit about his with web. And then I'll describe a little bit of my experience and where I think I've changed my practice to respond to the challenges that I'm going to talk about. I'm going to keep this open. So I see a question about the web device. Pascal, do you want to answer that? I'm going to interrupt for a second. Somebody's asking about the web device and what are the challenges that you faced at the beginning of deployment?
So the main challenge is to learn how to size it. I mean, that's the main thing. First, sizing it and know how to expect how it's going to shape in the aneurysm. Second is driving big microcatheters in aneurysms. You know, we're not used to driving 21, 27, and the 33 microcatheter in an aneurysm. So sometimes there's a buildup of tension with that. We're used to smaller microcatheters for coiling. So that's mainly.
Perfect, thank you. So back into Surpass. So, you know, Surpass is a device that's over the wire. If you're used to Pipeline, which is the product of Medtronic, that one is a lot easier to deploy. It's through a microcatheter. It's a 27 microcatheter. You bring it to the area where you want to deploy it and deploy the stent through the microcatheter. In this case, the device is over the wire, and so it has a lot of components. And the two very important points about this one is that if you want to deploy it effectively, you always need a triaxial system. And you will see in this case, we have an infinity catheter, a long sheath-like support catheter, all the way into before the Petri segment of the carotid, and then distally you see into the M1, M2, the Cat5 catheter. So you know, large catheters, very, very distally. Again, these are challenges with these devices that you need a lot of support. The way I approach this, and again, there's no perfect recipe, but I'm gonna tell you what I do. You know, it's a very cumbersome system. Pascal will tell you, it's not as straightforward as most other devices. A good analogy that Alex Kuhn is using for this device is that, you know, it's like a Boeing 777 that you want to fly it over to a destination. You know, it takes a lot of preparation, it takes a lot of knowledge and a lot of training to move this device places. When it does get placed in an area, has great flow diversion properties, but to get there might be very challenging. So we use an 8 French sheath, 9 centimeter infinity catheter, Cat5 offset Synchro 2 standard in every single case. We place the device tip to tip, which means we bring the device all the way to the end. It makes it easier for visualization because this is a very challenging device to see. We deploy the device in the Cat5 catheter, and that allows us, or the majority of it, and that allows us to really then manipulate how we can size it to the vessel. And sizing is an important aspect of Surpass that makes it easier, and I'll talk about this in a bit. Final positioning, typically Surpass doesn't move. When we find where we need to put it and we place the Cat5 there and then we deploy it, it typically stays there. I've had challenges with other devices where, you know, you're pushing the device and it moves forward with you. I haven't seen that with Surpass, unless there's a couple of cases where you do see it, and I'm going to talk about that in a second. I typically unsheath the first part of the stent, then push forward to get good well apposition. If you don't get good well apposition, you might have the tip of the stent really pointing in, and that can cause neointimal hyperplasia and really shrink down the vessel. I'll show you a couple of examples on that. Then I completely pull back the Cat5 and I deploy it like a pipeline after that. I push forward as much as I can. Some people will tell you it's a bend push. If it's straight, unsheath, I always push it because I wanted to have good wall apposition and achieve good flow diversion. Now, two techniques after deployment, which is a rare treat when you have Surpass, is that you can manipulate the stent after it's deployed, right? So when the stent is deployed, you pull the pusher. By pulling the pusher, the wire of the deployment is actually abutting the posterior genu, and it's pushing that part of the stent wide open. And then after that, I'm advancing the pusher to really push the forward part of the stent all the way forward. Then after that, we need to cross the device and keep that axis going in case we need to place an Atlas stent, in case we need to place another device. And for that, I cross, but in order to cross, you have to get all the components of your deployment through the stent. So, I'm going to advance the streamline, and then I'm going to advance the Cat5 back into the M1. So what are the common complaints that people have when they first try to deploy this stent? First, I think the most common complaints that the Cat5 is falling, the device is not opening. Very similar to what Pascal was talking about Webb. You're trying to go forward, the catheter comes back. In this case, much bigger catheters, the Cat5 might start falling behind the MCA as you're trying to make the turn into the MCA, because this is also a very stiff device. The way to deal with that is get more proximal support, get more distal purchase. So both of these things need to happen. I typically advance the Infinity into the pitcher segment. I haven't had any issues getting these large catheters all the way out there. And then I maintain forward pressure on the Cat5, and I give more wire distally as long as it's safe. If you have any resistance in your wire distally, don't push. Obviously, a lot of microperforations in this case is if you push. And then I would try, if the device is not opening despite all that, I'll try to move the whole device in a straight segment. For example, into the MCA, even if you're not going to deploy in the MCA, deploy it in the Cat, lock everything down, move everything in your position, and then deploy there. And this is a couple of these techniques. As I said, you can see, if you can see my cursor, you can see my Infinity is all the way into the pitchers, bending over there, and the device itself is into the MCA. In this case, we needed to go into the MCA, but things straighten out like this, and you're able to deploy the device. Another complaint that we get often is that the anatomy is straight, and I have no idea where everything is. This is a stiff device. You might straighten everything. You might not be able to localize the anterocroidal anymore, the PCOM, because things are pushed out of the way, big catheters and a big device. And in those cases, there's no real remedy or advice that I have. Most of these times, we try to visualize where things were and try to replicate it. But I also don't have any restrictions in my mind in terms of covering vessels. I cover the PCOM all the time. I cover the choroidal all the time. And so I really have no reservation about deploying the stent despite the movement. Some people do a run after the device is in position before they deploy it, but I tend not to do that. So where do I think that this device is better than other devices? I think sizing is a big plus of this device. It comes in 3, 4, and 5 millimeters in what we have in North America. I've almost 99% of the times I'll use a 4 millimeter device. I almost don't even have to measure the vessel. I always will use a 4 millimeter device. You can open the 4 millimeter device into almost a 5.5 millimeters in terms of sizing. So I have no reservation to push it open all the way to that, especially if the vessel is not smooth and it starts from 2, goes to 3, and then 4. You can use one device and one long device or short device, doesn't matter, but you use one device with sizing that's adequate. The stent will always open. That's a big plus of the stent, and you can manipulate it after the deployment by pulling and pushing the pusher. That allows you to make it abut the walls. That's what I'm talking about, the post-deployment control. Positioning is important. It rarely moves from where you want to deploy it. And the flow diversion properties, I think everybody will admit that flow diversion properties of this device are probably the best that we've seen. That comes with a cost, and I'm going to talk about that in a second. So as I said, sizing is important. I always use 4 millimeter stents no matter what, unless I have a very large vessel, say a basilar dolichoctasia, 7 millimeter vessel. There you might actually use a bigger stent. 99% of the times I use the 4 millimeter stent. And this is an example of where this can be useful. You're seeing, I'm going to use my cursor again. This is a young patient, came with a blister aneurysm, ruptured aneurysm. We couldn't coil it. We opted to flow divert it at the time. And the choice, I chose a pipeline stent at the time. And the reason for that was that I thought, and these are all anecdotal and probably, what I'm thinking, there's no science behind it, but I thought that the pipeline has less metal, so probably I'm going to have to put the patient less anticoagulation in the case of a ruptured blister aneurysm. So I decided to use that device. The challenge with that is that if a patient like him, where the vessel starts at 2 millimeters down here and it's about 4 millimeters up here, the vessel created this ledge, or the stent didn't open fully into the vessel. The blister aneurysm itself looked like it was flow diverting at the time, and the patient did great, went home after 14 days, no problems at all, stayed on blood thinners, came back, and then because of this endoleak from this part, type 1 endoleak from this part of the flow diverter, he developed a much larger suprahypophyseal artery aneurysm. Now you see it a lot bigger. And obviously this is a challenge in terms of sizing. If we were able to size appropriately for a vessel that starts at 2 and ends up at 4, we would have been able to treat the problem from the very beginning. So in this case, what we did, and now you see the aneurysm from the lateral side. So what we did is we placed the Surpass, and you see kind of how bigger those catheters are, right? It almost takes up the whole vessel when you do a run. And now we've placed a Surpass, you'll see it here, into the MCA, completely going from healthy down to healthy. One of the other benefits of this device is that these are long devices. You can use a very long stent and cover the whole area. Now, in this case, we also used an Atlas. So you see the tines of the Atlas stent to really keep the device open and well opposed to the wall. And I'm going to tell you why we switched our practice. So when I started, I didn't use Atlas at all. I would put Surpass stents without any support, but I found that there is actually benefit to adding Atlas in some cases where I'm not sure about the opening of the distal part of the device. Again, this sizing in this case was key, and I think that helped us a lot. Positioning also very important, especially in challenging situations. This is a petrous carotid aneurysm where you see the aneurysm is actually coming from this part of the body, and you're trying to deploy your Surpass or your flow diverter in an incline in this case. And I'm going to show this case also a little bit later, but again, positioning here, there was no movement and there was no forward issues, and you see again flow diversion inside the aneurysm. Now, where did we learn from our failures? I think straight segments are still a challenge with this device because the pushing will push this device forward in the straight segments, especially if you don't have a bend to support your device as you're pushing. Challenging genius are a big deal when it comes to this device. You really need to find a way to respond to these challenges. If you are not able to cross the device, what do? I think the answer to that is very straightforward. You just need to put more of your components of the device into the device. So, you need to advance your pusher, your streamline, and then your Cat5 into the device. Distal wall apposition can be an issue, and that can lead to neointimal hyperplasia, and we have treatments for that. And two other challenges are the proximal common carotid artery loops and proximal internal carotid artery loops, and I'll show you how we get around those challenges. This is a device where you need to get a lot of stuff, a lot of catheters up north, and if you have proximal loops, you might not have the ability to do that, and you might need to choose another device. So how do we deal with straight segments? So this is an example of a very straight, or the aneurysm was coming from a very straight segment. There was no bends, and we chose a relatively short device. In this case, I think it was actually, no, it was a 25 Surpass, but still it ended up, the straight segment was long, and so it ended up deploying there. The way you get around this problem is, I would say, what I do nowadays, because I found that if I keep pushing, the device is going to move forward and probably go up against the bifurcation or something like that in the distal vessel. So I'm less forceful at the beginning. I'm very patiently waiting for the device to open up nicely against the wall before I start pushing the pusher. And you might take a little manipulation at the beginning before you really engage and start pushing the device open nicely against the wall. Other things that you can do is if you use a longer device, you can be really sluggish at the beginning and then start pushing heavily when you reach a turn. And at that point, the vector, which is going to be in a different direction than the straight segment, that will allow the vessel to open, or the stent to open without any issues. So what about some challenging genius? And these are the three types of genius that we encounter when we try to deploy this device. This is a genius that's pushing, that's the posterior genius in particular is what's challenging for me. So if you have a genius that's directed backwards, that's one type. Upwards is the other type, and then back and up is the other type. For the first and the second type of genu, I don't have a lot of concerns. You can address these types of genus by the algorithm I gave you for the device not opening, meaning get more proximal support, get more distal purchase, the device will open. You might be a little challenged, but you have to go past these issues. The third one is where kind of everything, all the playbook gets completely thrown out of the window, and these are very, 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 very challenging to deploy. Surpass for sure, but I think the other flow diverters also are challenging. So for the first type of genu I spoke of, again, you have to get a lot of support, and eventually you'll be able to deploy the device. If you follow the steps that I said at the kind of the beginning, meaning a lot of proximal support, a lot of distal purchase, you'll be able without fail to deploy this device. As I said, follow the algorithm for not opening the device. Challenging genu number 2, again, this is the superior pointing genu. This is actually not that challenging, because most of the times what happens is once you go in it with stiff devices, the genu moves down, and you see here kind of how the genu straightened. It was all the way up there, and now it's straightened here as we deploy the device, and that allows you to actually deploy the device without issues. Now you see here kind of how lower, you see where the Cat5 is, where the true position of the genu is as compared to the roadmap, and so that it shows you exactly how the genu moved. Again, this will allow you to straighten. Now, the most challenging genu is this type of genu where it's pointing up and back. And those are very, very challenging in this case because they look like a SIM2 catheter. And if you're pushing forward in a SIM2 catheter, what's happening is the tip of the catheter goes down. And this is what you're doing in these cases. If you're trying to push forward in this configuration, the catheter or the tip of the stent is going to keep coming down. So you're pushing forward, you think you're deploying, and you are deploying, but the device itself is moving with you. And I make this mistake here where you see the stent is deployed here, the aneurysm is there, so I'm really barely covering the aneurysm, and most of the stent has fallen behind, forming a C. So these are extremely challenging, as I said, because you're dealing with kind of reverse thinking. It's like having a SIM2 catheter, and obviously my first deployment here failed, so what I did is I placed another stent to cover that area. Now you see the second stent is covering that area nicely and almost making a 360 loop in this particular patient. And when you deploy the second stent, things are a little bit easier because now the two stents touch each other and they don't really move. There's friction, and so you can sustain the second stent up there. What would have I done, what do I do in the future when I'm faced with these types of genus? Well, you got to be a lot more careful. When you deploy the stent, there's going to be a lot of movement. If you see your stent moving back, you have to keep going forward. It might take a lot of manipulation, but you might be able to do it right. This was the only case where I had to use two Surpass flow diverters. We didn't have to use two in any other case. All of the other cases were a single flow diverter, position was perfect. But this genu in particular is very challenging, and there's no magic tools, I think, to achieve good positioning in advance. How do you deal with distal wall apposition? When I started, I almost never ballooned, and I even more rarely stented these devices. And I've kind of moved my practice into using a lot of Atlas. And I'll tell you why that happened over the process. Now you'll see, I'm just showing an example here of where this is a patient who treated both sides of her aneurysms. On one side, you see a nicely open stent with an Atlas in it. On the other side, you see kind of how the stent doesn't look perfect in the opening. So it kind of this patient was right at the point as we were transitioning our experience from not using Atlas to using Atlas. And pictures that we saw that actually led us to use a lot more Atlas were follow-ups where you see a lot of neurointimal hyperplasia around the areas of the device where it hasn't fully opened distally, and similar problems here. So we saw these follow-ups and changed our practice, and you'll see kind of how this has been reflected in our experience. A couple of examples here. Again, the Surpass is deployed, and this is after two Atlas stents actually were used in this device. Really nicely open after you use the Atlas stent. And similar case from the AP view. Another case, Oh, actually, another situation where we're challenged with Surpass is the proximal loops. And I'm gonna talk about this patient a little bit more when I talk about our combined approaches. And I know Pascal also talked about percutaneous axis of the carotid artery. This case, we couldn't go up. There's a proximal common carotid artery loop that a long catheter would really not be able to negotiate. Just a Cat5 would negotiate it no problem, but then you need a very long catheter to go through that. So what we did is we accessed the carotid artery with an 8 French sheath, placed the flow diverter, Surpass in this case, and you see nice flow diversion in the dome of the aneurysm. So the answer to this is a carotid artery cut down or percutaneous access of the carotid artery, like Pascal showed in his case. Now, if you have a proximal internal carotid artery loop like this one or this one, I don't think Surpass is the right answer. These cases, if you try to put your infinity through this loop, bad things can happen, especially if the loop is proximally. You can cause a lot of bradycardia in this patient, and you can potentially have a catastrophic complication. I would not challenge these cases. You can easily navigate a Cat5 or an avian through this loop and get it all the way up. Treat the aneurysm with another flow diverter if that's what your choice of device is. You can use pipeline. Now there's other flow diverter, there's other flow diverters coming in the market soon. I know that we're talking with Pascal about it. Evolve, the kind of the new generation Surpass is coming, and so all these are options for these kind of patients. So how did I change my practice seeing all these challenges? Especially the where I was puzzled the most was kind of the distal the distal stent was never perfectly open in my eyes. And so I looked back at the 75 patients where I had 6-month follow-up with these devices, and, standard stuff for these patients, mostly females, unfortunately, with the brain aneurysms and regular age. And so the aneurysms ranged in terms of sizes and ranged in terms of locations. And we ended up using, as I said, mostly one Surpass, one case, we had to use 2. And we used Atlas in 23%, kind of the later part of our experience. We saw 34% of neointimal hyperplasia. So that buildup of tissue inside the stent. And as I said, these are stents that induce a lot of flow diversion, and probably the presence of metal really stimulates the formation of neointimal hyperplasia. And so we saw a lot of that. And wanting to investigate further of why this was happening, we looked into, kind of in terms of time-wise, when did we have the most neointimal hyperplasia and when we were kind of not seeing it as much. And you'll see that after October of 2019, you don't see much of this neointimal hyperplasia problem. And what changed then, it was us introducing the Atlas stent. So by introducing Atlas in your distal stent placement, if you, again, don't do it every time, but if you see that there's not even the slightest malapposition on the wall, it's very advisable to do it. None of the patients were symptomatic. None of the patients developed strokes, but then the blood vessel doesn't look perfect. And obviously that's something to consider when in the long term. We don't know if there's any issues with that. And I know there's big experiences from India with over 200 Surpass flow diverters where for cost reasons and otherwise people are not using Atlas stents, and there have been no complications. Like we've seen, we haven't seen any issues with these, but in terms of the way the vessel looks, it looks narrow. So, I really am challenged to accept that. And so I think introducing the Atlas really allows you to open the stent very nicely. And what I've seen anecdotally is after I introduce the Atlas and I do another run, flow diversion is a lot more potent. And as I said, I almost never balloon these. Maybe ballooning is another answer for these patients. So we did a multivariable analysis trying to look at really what made the difference in neointimal hyperplasia, and we saw that introducing Atlas really eradicated that problem for us. And so, this is kind of an overview of what we've done and what we've changed in our practice and how to overcome the challenges that come with this device. Obviously, this device has obvious benefits when it comes to size and when it comes to considerations of positioning, but then shortcomings when it comes to how challenging it is in terms of the components that you have to deploy and the large size of catheters that you need to get up there. And so I think looking at other devices, if you're not comfortable with such kind of big deployment systems, it absolutely makes sense. And there's a lot of options. There's a lot of options out there. And with that, I want to thank you and maybe give it back to Pascal.
Hey, great lecture, Kimon. I think you have one of the largest experience with Surpass in the country. You've done a great job. I'm really excited to see with the new Evolve how it's gonna be. It just, in my opinion, 23% of Atlas use is a lot. I mean,
there's been a lot of Atlas use, yeah. And when we were deploying,
if it's not correlated with complication, that's fine.
yeah, so we haven't seen any complications. I mean, the device itself, Atlas, you know, I mean, I'm a big fan. I know you are too. You know, it's a very benign stent.
We just published our Atlas series actually yesterday. It was out.
Yeah, and so yours is the stent assisted coiling, I'd say, right?
Yeah.
And maybe with web sometimes.
Yeah.
Yeah. Got you. Yeah, you know, these patients are anticoagulated, so I don't have to load them or do anything. And if I see any malapposition, I deploy a stent and try to keep it open. After using Atlas, it's really worked like a charm.
I don't know if I've missed it, but it seems that you don't do balloon. You'd rather do a stent.
Yeah.
You don't do balloon.
I don't do balloon because the reason I don't is if I find that these are challenging stents to recross if you have a wire or something like that. And if I miss the spot I want with a balloon, especially distally, and I want to go even further, I find that I fidget a lot, you know, trying to navigate through the stent again. And so I find that, you know, with the Atlas, kind of I can shape the stent nicely. And if you look at it in real time as you're deploying the Atlas, you can see the Surpass opening nicely at the same time. But a lot of them we've been able to open without a stent. You know, that not to be said that they always need an Atlas, but that's kind of where we are.
All right.
And so now, as Pascal's pulling up his screen, so you know we're going to move into a little bit more edgy stuff, and then we're gonna end up with the totally edgy stuff when Pascal's going to talk a bit about robotics. But so you know, Pascal has probably the largest experience when it comes to transradial approach for neurovascular lesions. And so he is the master of the craft when it comes to that. He changed his practice maybe a year and a half, 2 years ago, and then he went full speed on this. And you know, when we were together at Jefferson, he would use this technique for some cases, but now he'll tell us why he's changed his practice to completely incorporate this, and you know, kind of tips and tricks on how to really utilize this technique to our benefit and go away from the groin.
All right, thanks again. So this was the first publication from a cardiologist innovator, Lucien Campeau from Canada, and it was the first published series of transradial coronary cardiac cath, coronary stents, and angiography. And in the conclusion of his paper, he concludes that in the majority of the patients, this is free of significant complication because the hand, you know, has two supplies of blood, the radial and the ulnar, and that despite the fact that sometimes there is some complications in patients that are in the ICU because they have a long-term A-line in place. But really, when we do a procedure through the radial artery, it has a very, very low complication rate. And as you know, with the palmar arch and all the collaterals, it's having an ischemic hand is really case reportable in cardiology. And like everything in neuroendovascular, our predecessors, the cardiologists, started all that, and we've gotten a lot of things from them. So the shift from transfemoral to transradial was because there are a lot of data, mainly from cardiology, showing that there's decreased length of stay, reduced hospital cost, and improved patient satisfaction. Not just that, there's more data showing there's even improved mortality and disability and complication and morbidity in the cardiology literature. This is why both in Japan and Europe, the transradial approach in cardiology exceeds 80%, while it's still 40% in the US. There are multiple large trials in cardiology showing the superiority of the transradial approach. As you know, because of the incidence of the cardiac diseases, the cardiologists are able to enroll thousands of patients in their trials, and we have a lot of data. So two big trials, the RIVAL and the RIFLE, showed that transradial is safer than transfemoral, and it is associated with lower morbidity and even mortality. Following those trials, three of the largest societies for interventional cardiology in Europe, they issued a joint guideline fully recommending radial access as the first approach. So why not in neuro, and why do we have some hesitance? It's because we were not trained in transradial. I mean, all of us here were trained in transfemoral. I've trained 80% of my fellows in transfemoral. Even when Kimon was at Jefferson, we used to do transfemoral. We kept the transradial only for if patients had bilateral femoral occlusions or if they have difficult arches. So we weren't trained in that. And then there is a perceived difficulty in navigating the cerebral vasculature from the radial approach, which is true a little bit, but it needs a learning curve. So a lot of times as a human nature, we try to avoid changes and new techniques. So as I said, there is a learning curve. This is a publication from Pittsburgh showing that 16.2% improvement in procedural efficacy with the learning curve. It also showed cost benefit in the cardiology literature and a net hospital cost saving of $275 per patient using radial catheterization instead of femoral. This is a big Cochrane review of more than 30,000 patients showing that there is a decreased morbidity and mortality. So in 2016, actually, we were thinking not outside the box, but outside the groin. And this is a paper that we've published, Alternative Access to Endovascular Treatment for Cerebrovascular Diseases, where I looked at all the alternative access other than the femoral. And that time, as I said, we used to use the radial for cases where we failed femoral, so some of the cases. And then I start seeing more and more patients coming to my clinic. And when I say I'm going to do an angiogram, they would say, oh, are you going through the wrist? I was like, no. It's like, well, I just had a cardiac cath. They went through the wrist. And more I started thinking, why not do that? And then this was our publication in Stroke. When it was published, it was the largest series published to date of transradial approach, where we looked at 223 patients who had diagnostic angiograms and procedures. Where in the diagnostic angiograms, we showed after a certain learning curve that it was shorter than the transfemoral. And then what we did is we took patients that already had a transfemoral approach once, and then they had a transradial approach, and we sent them a questionnaire to see the patient satisfaction. And we asked them all those questions about radial compared to femoral. And across the board, we had all in favor of transradial approach. Just as simple as the mean stay in the diagnostic angiogram, outpatient angiogram, was 5.5 hours in PACU as compared to 1.5 hours in the transradial approach. This is one recent paper we just published. It came out 2 weeks ago about the complications of the transfemoral approach in general. This was a literature review. We looked at all the randomized controlled trials for not necessarily femoral, but just neuroendovascular procedures done through the femoral approach. And those are all kind of complications that you can have from the transfemoral approach. And I mean, the complications rate in the randomized controlled trial are up to 5.1% of that. So what do we need to be able to adopt a new technique? Because the most important and difficult, challenging thing is to convert your practice, because it's not only you, it's you and your team. So the teams need to follow protocol. We shouldn't be reinventing the wheel every single time. And then whoever is asking for a change, you need to be able to invest and time to educate and find best practices. I can't show up to my INR suite one day and look at my nurses and techs like, you know what, we're going radial. All right, see you. Just prep the patient, I'm coming back. You cannot do this. You need to invest really and educate them. It's not gonna go autopilot at the beginning. That's why it's tough to change, because right now, people going transfemoral, they are used to, everyone knows how to do the transfemoral, and they come in, they call them once the patient is ready, and they do their cases. So it's very important to communicate with experienced colleague in the country. Like when I first started, I used to communicate a lot with Eric Peterson in Miami. He has a huge experience in transradial, and then we start learning from each other. Very important to acknowledge failures and then always give positive reinforcements. That's really important. You need 50 to 100 consecutive cases to be able to feel comfortable. You cannot just pick and choose. You need to commit as like, I'm gonna do 100 consecutive. If you're gonna start doing one and every other one, it's not gonna work. So at the beginning, the tax fellows, INR nurses, they're gonna hate you at the beginning because they are not used to that and they're not gonna like it. But the PACU and NICU nurses will love you because the patients are staying less out there. The patients and families will love you. And then after you figure out all the protocols, positionings, catheters, everything, everyone will be on board and it makes sense. One question I always ask everyone in the room at the beginning, now all my team are convinced about radial, but I would ask them, if you have to have an angiogram, would you want femoral or radial? And everyone will say radial. So it's very important to figure out a lot of things as simple as positioning, sheath, catheters, anesthesia, cases not to do at the beginning, complication management, and then convince the administrators that it makes sense financially, because you won't have a full support unless you show them that it makes sense from a money standpoint. They're gonna always ask you, how much are you saving? Well, you're saving a lot. Closure devices, the compression bed is very cheap as compared to the closure device we use for femoral. Time in PACU. This is all time of nurses in PACU that stay over time to stay with patients and recovering patients. Wasting the time to apply pressure. This is all labor. You're sending someone to apply pressure at the groin. That's also a wasted labor. Cost of CT abdomen pelvis. We have a very low threshold. If I do a case and then the patient is in PACU, and if I get any phone call from PACU before I even hear what they are saying, I would say, do a CT abdomen and pelvis, So we have a low threshold to do that. Serial H&Hs, vascular consults, the cost of complications, the cost of DVT related to delayed ambulation. As you know, the transfemoral approach, you're not gonna ambulate the patients right away. And then return visits to the ER. Anytime there's anything and the patient would call you, you're gonna tell them, oh, go to the ER to look at the groin. Because why? Because this is something you can see. If there's any retroperitoneal hematoma, you can see. But here, that's my wrist, right? Nothing can happen that I cannot see. I can, on the phone, tell the patient, well, what's happening there? It's like, there's a hematoma. It's like, how much, how big, what is it? Just put some pressure. Can I say this for the femoral? I can't. I can't tell on the phone if the patient is bleeding retroperitoneal. So as simple as setup for diagnostic angiogram, I'm going to show you here. So this is the radial board. It's very important. And you need to build up a platform. So you cannot have this abducted arm up and then a bridge of catheter and everything is dripping and everything is messy. Because that's not good. So what we're doing, we're building up a platform for at the end to have the radial next to the femoral. So you build up your platform. Now you have a platform. There's no arm opened like this. There is no bridging of catheters. There's no dripping of blood on the floor. And this is important. Then after you put your sheath, you're gonna give your cocktail, which is 3 milligrams of cardine, 200 microgram of nitro, and 2,000 units of heparin. Then for a diagnostic, you're gonna go with the SIM2. My favorite catheter is SIM2 Penumbra because they have a 120 and 130, and it's not. It is a little bit robust. It's not too flimsy. The Glide catheter, the Terumo SIM, the problem is it's 100 centimeters, so it's short, and sometimes if you're going inside a bigger catheter to slide it on it, you're not gonna be able to do it. Definitely, I won't use the SIM2 Cook because it's too stiff. I use the SIM3 because it's longer in case I want to go into left vertebral artery. Now, for my procedures, and if I want support, I would go 6 French shuttle sheath, long sheath. I used to do the Cook. I've tried the Infinity, but my favorite now is the Ballast. The Ballast is the best long sheath for transradial approach. It follows, especially on the left side, it doesn't herniate in the arch. This is when you need support. In 70% of my cases, I don't need support. What I do is 6 French short sheath, and then whatever catheter I want inside of it, either a Sophia, a Navion, a Benchmark, or even a 6 Envoy. Those are the sheaths I use. Those are low profile sheaths. So if you look at it, the sheath will have an outer diameter of a 5 French, but the inner diameter is an inner diameter of a 6 French. So there's always a 1 French difference as compared to the femoral sheath. There's the slender sheath from Terumo or the Prelude from Merit. I started using slender. Then the slender, they tend to bend. They are flimsy, they bend. The Prelude from Terumo, from Merit, this one, it gives you the same advantage of a slender, but it doesn't bend. So this is my favorite sheath, the Prelude from Merit. And this is my cocktail that I give. Ultrasound is your best friend. At the beginning, I was like, oh, who needs ultrasound? Well, no. When I started using ultrasound on every single case, my conversion rate to femoral decreased a lot and is close to 0 in diagnostic. So that's the vessel. Then you puncture it, and then here it is, and then you go in. Especially in Snuffbox, it decreases your conversion from Snuffbox to regular radial. This is your artery here. You see it on the ultrasound, and you go in and you go in with your needle, as you see here, and then you're gonna pull back, and then you'll see your blood. Here it is. I'm in. And then you're gonna insert your sheath. Those radial sheaths, the dilator doesn't have a ledge with the sheath, so you don't even need to nick the skin. You just go in and it will go easily. What about Snuffbox? So Snuffbox is this area, the anatomical Snuffbox between the 2 tendons. And this is a really distal branch of the radial artery. And more, we started doing Snuffbox. And because first of all, for diagnostic, the patient is awake. You don't have to turn the hand, the wrist, and it's uncomfortable. So you leave it at the neutral anatomical position of the patient, and then you do your diagnostic through the Snuffbox. You keep the radial virgin for when you're gonna bring the patient for the procedure. At that time, you'll have a fresh area and you do it. More and more, we're doing procedures through the Snuffbox, not only diagnostics. And we just published our paper in operative neurosurgery. It's actually the largest single center series of Snuffbox with that. So with the Snuffbox, you can abduct the arm all the way, so you don't even need to tilt your table. You can do your run, and you can see it here. You don't have to tilt the table for that. So as I said earlier, those are the advantages. And this is just a case showing that's the area of the Snuffbox. That's the position of the hand. This is the old technique I used to use to puncture. Now I don't do that. I just go with the sheath, with the needle that comes with the sheath. Here it is. I'm puncturing the vessel. I'm going in. And here it is. That's the old sheath that I used to do. Snuffbox band. That's the band. There's a specific band for the Snuffbox. As you see, I inflate, then deflate to have a little bit of bleed, then inflate to avoid overinflation. This is the paper that we just published, and this is from our paper. And Snuffbox is interesting in left-sided radial. In left-sided radial, you can put the arm of the patient on the belly of the patient, and here it is. You can stay on the right side of the patient, and you can go ahead and puncture it. Those are 120 procedures we've did between diagnostic and procedures. And as you see here, complications, conversion to transfemoral was 0. Complication minor was only 2 patients, 1.7%. When I say minor, it means we even counted if the nurse called you and said there's a little hematoma and you had to inflate the band again, we called it a complication. So no major complications. And that's the Siemens catheter that we use. Radial band technique, here it is. We need to avoid overinflation because this is correlating with long-term occlusion of the radial artery. So what we do is we start inflating. We pull the sheath. That's the sheath. This is on a baby. Transradial I'm doing on a baby. So I'm gonna inflate until I don't see bleeding. Then at that time, I'm gonna deflate until I see bleeding again. At that time, I inflate a little bit again, and that's it. This is avoiding overinflation. After so many angiograms, I stop prepping the groin. Again, for diagnostic, I don't prep the groin anymore. This is what I do. For procedures, I still prep the groin, but soon we're gonna stop prepping the groin. So it's all about shaping the Simmons catheter, because this is our catheter of choice. So you can shape it in the ascending or the descending aorta. So that's the Simmons catheter. Here I'm shaping it in the ascending aorta. As you see, it's shaped. Here is another one showing it. Here it is. You give it a tug, it's shaped. And here is one where I'm shaping on the valve, on the aortic valve, the wire bounce. If the wire bounce up, at that time I'll follow with my catheter. A lot of times the wire would bounce up. I'll take it, I'll advance my SIM2, and then it's shaped. Moving to another vessel, all you need to do is to keep the shape. You don't pull, you push, and you keep the shape, and you move to another vessel. This is being more efficient. How to pull out? You need to pull and then push. In those cases where sometimes you push, it goes up, all you need to do is twist a little bit while you're pushing, and it will keep its shape. Here it is. I twisted, I pushed it, it kept its shape. Now I would move to another vessel. Here it is. I'm showing you. I'm pulling back, and then I'm gonna push, and then it kept its shape. Moving from right to left, you puff, 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 then it will fall on the left side. Here it is. Now I'm on the left common. Left vert. This is where I use the SIM3 because it's long. Here it is. I'm in the left vert, and then I'm gonna puff, puff. And then sometimes the vert, you need to go and give a lot of wire for the catheter to follow. Left ICA, you need a lot of wire, and it will follow. Here it is. You see my SIM going all the way up. Check here. So I hooked, I need to twist, and then I need to engage and pull up. So this movement is very important. So I see I hooked my left common, but this shape is not stable. You need to twist it, and you need to know what direction you're gonna twist it. If the opposite direction, it will fall down. So here I twisted it, stop. I twisted it, it looks good. But again, it's still too low. If I'm gonna try to go up, it's gonna fall and herniate. What I need to do is reduce this loop to hug the angle. So I twisted first, and now I'm pulling. Here it is. I hug the loop. Here it is. I'm showing you here. It's too low. I need to hug the loop. So I'm gonna pull back and then reduce. Here it is. It hugged it. Now it's in a stable position. Left vert, you go behind, you go distal, then you twist and pull back. And then you pull back again. You're looking medially. And here it is. I hook the left vert without the wire. This is another technique with using the wire. Again, it depends on every patient. I'm doing, look at this angle here. Because I have a lot of wire, I was able to do it. Sometimes for left side, if the left side is difficult, your bailout is a Berenstein. So you go with the Berenstein, you turn it up, you hook it, it's easy, and then you go with the wire and it goes up. Here it is. So remember, Berenstein is an option. Bovine arch is the easiest, is to go directly with the wire. That's the best indication. If you have a bovine arch, you go transradial, you don't need even a SIM catheter. Pulling out, make sure that your SIM catheter is straightened to pull. If it's shaped, you cannot pull, you can damage vessels. Left radial, we talked about that. So this is the left radial. We've used left radial in a lot of cases. It's interesting because you're avoiding dominant hand. When you go left radial, your wire would always 90% of the time bounce on the aortic valve. And then what you do is you follow with your SIM2, and this is how you shape your catheter. We have a paper under review on a big series of left radial. When I say left radial, I'm talking about other than the left vert, because it's obvious if your target is the left vert, only left radial is the best way to go. But here I'm going left internal. The only challenging vessel with the left radial is the left internal. you cannot go from left radial to left internal. You can do left radial to left common, but in only 10% of the times we were able to catheterize selectively the internal. This is because of the acute angle. Look at this acute angle. The vector force tends to herniate in the arch. Ulnar, it is an option. It's not an option if you have a patient that come back with the occluded radial artery. This, I wouldn't go ulnar because that's the only source of blood to the hand. You'll take away all the benefit. But if someone has a small radial artery, you know that from the diagnostic angiogram, I would schedule the treatment through the ulnar. This is a case of ulnar, where the ulnar was bigger. When the patient came back, I treated her through the ulnar. All you need to do is shift the radial band to the ulnar. Intra-op angiograms, it makes more sense from an ergonomical standpoint to do the intra-op angiogram through the radial artery, because you are standing away from where the tech is standing. So this is where we stand on the other side, and we're doing all the intra-ops actually transradial. It's much more efficient. This is our paper on transradial intra-op angiogram. This is our setup, as you see here. Before, and Kimon used to remember, we used to be jammed all in the left-sided patient to do the femoral. Now, no more jamming anymore. That's the anesthesiologist, that's the tech. Here I am on the other side doing the intra-op angiogram. Spinal agram, you can do it. The only thing is you need to use the long SIM2, the SIM 130. And sometimes if the patient is too tall, it's going to be challenging to reach the lower lumbar, upper sacral. But otherwise, it's totally feasible. This is a case of a transradial spinal agram, where, as you see, with the SIM2, I'm able to catheterize all the segmentals. And then here is the spinal fistula. So the way I talked about earlier, doing sheathless, so I go 6 French long sheathless, I put a 7 French short sheath to dilate, then I exchange over a Terumo glide wire, and then I go sheathless with 6 French long sheath. This is how I do all my strokes and procedures. This is one of our papers showing that newly FDA approved devices done through the transradial. One of them is the Kimon, I use Surpass. That's
I know. Only if it goes to the wrist.
Yeah, here it is going up and, you know, doing the case. Snuffbox for web, I showed that. Transradial approach for flow diversion, we published this. We showed that it's feasible. Again, I'm gonna go, because of the sake of time, I'm gonna go quickly on this. Strokes, I'm gonna show you some compilation of strokes. So strokes, I wouldn't do it at the beginning. I would switch first to elective cases before doing stroke, because it's tough in strokes to convert, because you're losing time. So stroke was the last thing I moved on to do transradial. And at the beginning, I didn't do transradial in the middle of the night, because this is when my fellow starts and I'm on my way to the hospital. I don't want them to struggle. And first, I didn't do left internal carotid territory transradial. Then with the ballast, we started doing the left, and now I do all strokes transradial. We just published our series. We compared both transfemoral and transradial. There was no increased time or anything. This is after the learning curve, of course. This is the transradial approach for stroke. As you see here, non-statistically significant. Everything was the same. Fluoro time, contrast time, procedure time, non-statistically significant. So it makes sense for strokes, because those are patients that have type 3 calcified arches. They are old patients. They are already on anticoagulation. They already got TPA, so higher risk of retroperitoneal hematoma. And for some reason, PVD goes mainly to the lower extremities more than the upper extremities. You see patients with bad vessels in the lower extremities, but the uppers are okay. And then you can early mobilize those patients. So that's the catheter I use. Really, I mean, I'm going to show you a compilation of really tough arches that were all done with ballast. So look at this. I mean, 360 loops. It follows nicely. It goes up from left to right. Same thing. That's the ballast. Another case.
It's like a treatment, huh?
Here it is. Look at this angle here, and it's following nicely. AVM embos, same thing. Transradial, again, coiling. IAC for babies, transradial, that's a baby. I go only with a marathon from the wrist up. So I have a marathon here going up to give the intraarterial chemo for retinoblastoma. And then I would go up the 2 microcatheter, either prowler or marathon. It depends if it's herniating or not. This was the prowler. Here it is. I'm catheterizing the ophthalmic artery through the radial. It makes sense mainly in kids, not to sedate them after the procedure, and they are able to get mobilized right away. I mean, those kids used to be sedated 6 hours. Here it is, a kid leaving an hour after the IAC. This is our paper on intra-arterial chemo with through the transradial approach. Another collaboration of feasibility and safety of transradial in pediatric neurointerventions. Complications. So it's very important to advance through roadmap, because sometimes you think that you're in the right position, but you're not. This is an extrav in the forearm. Again, it looks scary, but it's not dangerous. All you need to do is apply pressure for 5 minutes while looking at the SAT, and here it is. You apply pressure on the forearm, and that's it. As for an extrav in the retroperitoneal, it's a big deal. Radial loop, it's very important to recognize them, because with every radial loop, there is an accessory radial going up. If you go blindly, your wire would go in the accessory radial. You won't be able to push your catheter. You're going to have spasm. Well, you need to go through the radial loop, straighten it. Multiple technique to straighten it, either with a glide wire or 3-5, or with a microcatheter and then 18 or 14 wire. You will straighten it, and then you will go through it. So spasm, it happens. You need to be patient, and you need to give your prophylactic dose. You need to deepen anesthesia. If the patient is in pain, it means it's spasm. Give more calcium channel inhibitors. Inflate the blood pressure cuff. If you inflate the blood pressure cuff, it creates ischemia, and then your vessels will relax and you'll have vasodilation. And worst thing, if it happens, you can inject nitro transcutaneously. I've never had this happen, but some of the colleagues have done that. Another complication, this is a 90-year-old patient, big pseudoaneurysm. The problem is the patient had a stroke. We treated her transradial. She went to a nursing home. No one paid attention to this. Pseudoaneurysm at the wrist is the easiest to treat. If you pay attention to it, you put a compression band and it's treated. But this patient came in too late, and she had to have surgery. So infection, I had a patient that had some kind of infection, inflammation, gave her antibiotic. She did well. Avoid the arch dance. This is what I call the arch dance. The SIM2 is a catheter that's made to be turned only once, 360. Don't switch it and turn it and have the arch dance more than 360. That's what's going to happen. It's going to break. This is a SIM2 that we retrieved because it got broken. Recognize your anatomical variant. This is an arterioallosuria. This is a contraindication for transradial because the subclavian hooks all the way distal. And it's in around 5% of the cases. You may be able to do some diagnostic. You won't be able to do a procedure. Okay, for the sake of time, I'm going to go. So what's this? That's a blank screen. Well, this is the retroperitoneal space. It's a black hole. You don't know what's happening there. As compared to this, comparing to the retroperitoneal space, you have the wrist. Everything is seen. You can see everything here. So I'm going to go quickly on this. And I think it's a safe approach, less complication, better patient satisfaction. It's a learning curve. You need to commit to it and should be used as a primary approach. When you adopt a new technique, there are always plus and minuses, like what you see here.
Toyota and Lexus luxury models will come with Amazon Alexa. Alexa, turn on the AC.
Turning on AC.
Finally, a virtual assistant to help you navigate.
Alexa, where's the nearest gas station?
Nearest gas station in 1.5 miles.
And to help maintain your vehicle.
Alexa, order more brake pads.
Ordering new brake pads. Although maybe if you didn't stop so close to the car in front of you.
I left plenty of room.
You drive too aggressively.
If you were just quiet for 2 seconds, 2 seconds.
She'll talk to you literally the entire time you're driving.
I think you should have turned back there.
I know where I'm going!
Hi, you know why I pulled you over?
No, officer,
Because we were driving 72 miles per hour in a 45-mile-per-hour zone.
Anything else I should know?
2 miles back, we rolled through a stop sign without coming to a complete stop. Also, there are illegal fireworks in the trunk.
Sir, I'm going to just step out of the car, please.
Toyota and
Thank you.
Thank you, Pascal. That was a great lecture. That's really amazing. You know, the experience you have with transradial. One question about the Snuffbox: how big of a sheath do you put there?
So I put as big as a 6 French long sheath, so 6 French shuttle. So the 088 ballast, I'm able to fit it there in the majority of the cases. That's why more and more I'm doing even not diagnostic, but just therapeutic procedure through the Snuffbox. The Snuffbox can dilate up and can take a bigger.
Gotcha. And then, I mean, with a cocktail, you dilate that.
So the 6 French shuttle equivalent to a 7 French short sheath.
Yes, yes, yes. And so you say you use that when you were saying before that you were using a 6 French long sheath without the short sheath, you meant the shuttle.
Shuttle. So 6 French shuttle, which is the same, like Cook shuttle, which is the same size than a 088 ballast or a Fubuki or a Infinity. Same thing. Sheathless. I use those sheathless because if you use them with the sheath, you need an 8 French sheath. You're not going to do that.
You have a bigger ID. Do you do a follow-up ultrasound at all to see the radial if it's occluded or no?
I don't do a follow-up ultrasound when they come back for the treatment. The rate of occlusion is around 2%. Asymptomatic. We've never had any issue.
And how often do you reaccess the same radial? Say you did a diagnostic radial.
So we always reaccess when we want to do a follow-up. We reaccess it, and in less than 5% of the time, we're not able. At that time, we'll go on the contralateral side. As I said, left side is feasible.
Gotcha. All righty. So I'm gonna go quickly through my part on combined approaches because I really want us to get to Pascal's robotic stuff. So I think that's a lot more in the interest of time. I'm going to skip through a lot of things, but I just want to kind of complete. I mean, a lot of us are familiar with ephemeral approaches, and we do radial only when we kind of need it for, say, a challenging anatomy. But Pascal kind of shows us how this can be more of a mainstream approach with the obvious benefits that he is discussing. But there's some challenges where, you know, femoral is not an option necessarily, and radial is not an option, especially when we have challenging anatomy proximally. And that's what I want to talk a little bit about, and how we can do open approaches to the blood vessels of the neck. And, you know, I'm going to discuss kind of the indications for these combined open endovascular approaches and demonstrate the access options that we have and identify the closure options. Again, Pascal showed you a percutaneous access to the femoral of the carotid artery, and then use of an angioseal device. I'm going to tell you a little bit about my preference on these things, and then I'm going to show you a few case examples. So first of all, you know, there's 2 blood vessels in the neck that we can access with combined approaches. One is the carotid artery in the front, and the other is the vertebral artery in the back. I know some of you might hear me say that we access the vertebral artery doing a cut down and might cringe, but it's really a great option, especially when you have somebody with you that is, or you are familiar with accessing the vertebral artery transcutaneously. So for the common carotid artery, what are the indications for us to go combined approaches? One is a proximal common carotid artery loop that you're not able to straighten with your tools. A common carotid takeoff that's preventing you from going up through the radial or through the femoral path. Extensive aortic arch atherosclerosis. You know, there's some older patients where the arch is so atheromatous that the access is almost impossible or even dangerous because of the possibility of hitting a part of the plaque and causing a stroke. And say some other issues are if you have a patient with aortic arch reconstruction, prior dissections or things like that, that you have a very challenging time going through, you know, either the radial or the femoral artery. You're pretty much locked out from metal or from dissection flaps. And those are good cases to go straight for the neck. So what are the access options that we have? You know, we can use a 6 French sheath in the neck. You can use an 8 French sheath in the neck, right in the common carotid artery. I wouldn't recommend sticking the internal carotid artery, especially if it's low, with an 8 French sheath. You're going to cause a lot of spasm, but the tip of your 8 French sheath can very nicely be directed into the internal carotid artery. And you can also go with a catheter without a sheath, like Pascal is describing for the radial sometimes, especially in the vertebral artery. In the vertebral artery, I find that trying to put a sheath in can be extremely challenging because you have a very short area in the neck before the vertebral artery goes into bone. And in that short segment, putting a sheaths tend to be stiff. You can use a catheter, a glide catheter, or a hydrophilic catheter, much easier to go into the vertebral artery. So I'm going to go quickly through these examples again. I want to give Pascal a little bit more time for his stuff now. This is what we would do in the proximal common carotid artery loop. I showed you this case before. You see the 8th French sheath right here. It ends up, the tip of the sheath ends up being in the internal carotid artery. And you see, again, this is deploying a very stiff device like a Surpass through a direct carotid approach. And here's the flow diversion in that device. Again, this patient, the proximal common loop, and it was not possible to navigate even a Bernstein through that loop to treat, to even do the diagnostic. So that was a good option for that patient. If you have tracking challenges, for example, in this case, this was kind of the anatomy when we looked at it. You cannot really see it in this picture, but it was multiple loops and trying to navigate to go up. The catheter was falling frequently. Without transradial was probably going to be a challenge in the same direction. And so we went straight into the carotid artery. Now you see this is a carotid artery cut down. You see our surgical retractor here. And this is just a run through a micro, through our dilator actually before, because we wanted to confirm our position. So the tip of the dilator is the internal, and then you have the external here. And this is the aneurysm, and this is just the stent-assisted coiling of that aneurysm. Now you see the final result. Other challenges, that's another aneurysm right there. In this case, again, tracking challenges down below in the arch. So again, stent-assisted coiling. This is the final result of the stent-assisted coiling, and this is, you can see our clips and our surgical retractors. What I want to show you here is the spasm in the internal carotid artery. Our sheath was a bit too high in this case. This was a 6 French sheath. And again, internal carotid artery, very sensitive. Our sheaths are fairly stiff at 6 to 7, and then 8 French can be very stiff, cause spasm. In these cases, obviously, give verapamil or some other treatment. Be patient, go back up, and there'll be no issues. If there's an aortic arch endograft, that can be extremely challenging. This is a case where you see the endograft here. In the case of somebody who had a thoracoabdominal aneurysm, you see the endograft here. We tried to even do a diagnostic angiogram, transfemoral, and it was close to impossible. Same thing as transradial. In this case, you really have no option. You're locked out outside. You go straight into the neck. Again, you see a small retractor here. We're not even using a big retractor. These are the tiny retractors. The incision is less than an inch. I'll tell you why I like the direct access versus the percutaneous, but that's operator preference. In my hands, I think it does better in terms of control, but whoever is comfortable with either option is fine. And this is kind of what the patient looked up north. These are the aneurysms in the periophthalmic region, one ophthalmic, one probably suprahypophyseal, and this lady got flow diversion. In this case, we used pipeline, not Surpass. We ran out of length. So Surpass was not a good option here. So you see kind of the placement of the stent, again, all done directly in the neck. Other issues can be aortic arch atherosclerosis. I don't have a picture of the atherosclerosis here, but I have a picture of the direct carotid stick. You see the retractor is here, direct carotid stick. And this is the aneurysm, kind of heart-shaped aneurysm, bilobed, again, stent-assisted coiling. How do you close these approaches? Well, Pascal showed how to close the approach, with an angioseal, which I know a lot of people are doing more and more in stroke. I'm a little hesitant with angioseal just because I'm afraid of the possibility of either dislodging it or having maybe, I'm not comfortable in my hands with the possibility of failure of the angioseal and the possibility of carotid blowout, and then having to control that. So obviously options are manual compression, angioseal, or suture. And that's why I like the open approach, because I'm able to put a 6-0 Prolene per string suture when I put the sheath in. So the second I pull the sheath out, I can just pull that and close it in 1 second. And it feels to me like a carotid endarterectomy, at which point I have full control of this. I have proximal and distal control with loops, and that allows me to very easily control the axis. And so the cut down part of the procedure in the carotid doesn't take more than 10, 15 minutes. In the vertebral artery, it's an operation in and of itself, and I'm going to talk about that. But for the carotid artery, straightforward, and so I think it's worth the effort. So what about the vertebral artery? So these are very uncommon. Obviously, cut down to the vertebral artery, extremely uncommon, and it's a kind of a last resort in cases. And generally, if you have challenges with the vertebral artery through the femoral route, the radial route is phenomenal for these options because you're in the subclavian artery eventually, which is a straight shot into the vertebral artery. But we might be faced with challenges. One of them is a vertebral artery loop that you're not able to negotiate for whatever reason, or significant atherosclerosis at the origin of the vertebral artery. And if you have a lot of ather at the vertebral artery origin and you don't want to put devices or catheters through it, then you can consider that. I know that some folks have done a percutaneous approach to the vertebral artery. In my hands, I think that's quite challenging, fairly deep and probably a lot of complications that can stem from that. So other issues, as I showed before, if you have that reconstruction issue with dissection or something else, you can access, I would say you can access the vertebral artery with a sheath or without, but in my experience, without the sheath is easier because of the short segment you have, and typically the length of the sheath is much longer than that. So it would hit the point where the bony anatomy gets in the way. You can go straight with a microcatheter. So, if you have a short access, a small access into the vertebral artery, just a microcatheter is adequate. But the way we've done it in the past is pretty much open 3/4 of the vertebral artery, thread a catheter without the sheath, and after that, close the vertebral artery end to end, doing anastomosis like you would do with a bypass. And so if we have, I'm going to show you a case of that challenge. So here was the vertebral artery, and it had a couple of loops, but those were generally not an issue. Loop here, loop there, and there was significant atherosclerosis here. You cannot see it because it's the unsubtracted image, but there's a big rock of calcium here. So we try to navigate it and straighten the loops. The loops weren't straightening, and there was significant concern about the calcium in that area. This lady's other vertebral artery, which would have been our regular path there, was hypoplastic. So really she had one vertebral artery that was working adequately, and that was challenged by proximal atherosclerosis and loops. And again, we were not able to navigate them adequately. And she needed stent-assisted coiling. Now, if you need straight-up coiling and I can get one microcatheter through it, even if I can stay at the origin, it could be a long reach, but you might be able, depending on some anatomies, you might be able to get there. This lady needed stent-assisted wide-stented coiling, and so I decided better to go straight into the vert, and this is what we did here. You see, this is a Navion 072 right here where the tip of my catheter is, going straight into the vertebral artery. The vertebral artery was opened at the neck. 3/4 of the artery were exposed. Proximal loop in the proximal component, the 072 all the way up, and then you do your angiogram, obviously, ready for the treatment there, not just an angio. But the approach takes a while. It requires a significant incision, multiple layers. You have to remove the scalene fat pad. You'll see the brachial plexus, and then you'll see the vertebral artery emanating from the subclavian. And you have about 2 to 3 centimeters of a landing zone to get in it before it goes into the bone again. So really challenging when it comes to that very, very short area where you can intervene. And you see the 072 catheter. This is bareback catheter, no sheath into the vertebral artery. This is the final result where you see one stent here, one stent there, coils in the aneurysm, and this is kind of the lateral. Again, you see a lot of clips and surgical retractors getting in the way. One challenge that I find with these combined approaches is that for us to do the cut down or the vertebral artery approach, the patients will be in very weird positions for the endovascular side of the equation. And so we have to either change the position of their head, or we might have to repeat a 3D. But repeating a 3D image in these patients can be extremely challenging. There's a lot of drapes, and it's a big production. So we try to avoid repeating 3Ds. These are not straightforward cases, obviously, and we try to do them as little as possible, but they're great options if you don't want to do a craniotomy. And obviously craniotomies are great. We do them. but we want to avoid them in general if we have other tools. How do you close the vertebral artery? Well, I would not put any closure device to the vertebral artery, too small of a vessel. Either manual compression if you do percutaneously, which I think is almost impossible because it's extremely deep, or interrupted cycloprolene when we do it open. And that's the best way, end-to-end anastomosis, and that's what we would do. Post-operatively, treat these like a carotid artery, like a carotid endarterectomy. So you have monitor hemoglobin, do neck checks, and standard neuro checks. Patients go home the next day. I don't prolong their hospitalizations for any reason, especially with these treatments. So it really doesn't change much of what we do. And you know, with that, I'm gonna finish on the on these approaches and kind of close the access challenge component of the webinar, and give it to Pascal, because I think the last part is going to be the most exciting, talking about robotics in the future and kind of how he's tackling this this new tool to allow us to do procedures not from the room but outside the room, and he's going to talk a little bit about the pandemic considerations and how those fit with using robotics.
Great lecture, Kimon.
Thank you. And I saw Pascal's robots the first time via social media, and I called him right away asking, what's up with that robot thing? And so I'm very excited to hear what he's got to say about it.
All right, thank you again. So as you know, the likelihood of a good functional outcome in stroke decreases by 12% for every 30-minute delay in recanalization. And we know that a little bit more than a third of the population of the stroke patients get to a comprehensive stroke center beyond 12 hours. So the pre-hospital delays are mainly the main reason why a lot of times we're not able to intervene in acute stroke, or if we intervene, we're going to have not a good outcome. So the geographic disparities in stroke outcomes are well described, especially if we look at the stroke belt, mainly in rural areas and remote areas. And there is a lot of regional variation in stroke mortality because of this disparity. And we know also from a large paper from neurology that under optimal conditions, a very large proportion of US population will be unable to access a comprehensive stroke center within 60 minutes. So what have we accomplished in stroke so far? We have accomplished a lot. We have been able to act on many variables. First, the devices. We have more and more new devices. We're able to open vessels much more than we used to do before. We've accomplished a lot in screening methods for which patient is a candidate for a mechanical thrombectomy. We've accomplished a lot in timing and streamlining the process to bring patients directly to AngioSuite, creating stroke networks, telemedicine, mobile stroke unit, specialized ICU care, and we've accomplished a lot in prevention also. But there's one area where we haven't done anything yet, one area of uncharted waters, and it's the remote stroke interventions. So we're all familiar with those famous robots, and but you're not familiar with this robot. This robot looks a little bit different. It's not as cool as the other robots I showed you, but it's practically like telling the patient, you don't have to reach for me, I will come to you. This is the robot. It has a robotic arm that's hooked to the endovascular table, to the AngioSuite table. And then the console, the desk is remotely placed anywhere you want. So everything is loaded here, and the operator would sit here and then would manipulate all the wires and catheters. And this is the first remote coronary stent that was done in India around a year and a half ago, 20 miles away. The operator was at a temple. This is where the console was, and the patient was at a hospital 20 miles away, and they were able to do the first remote coronary stent in the world with this robot, the Corendus robot. So that's the console that's outside. In our case, it's in the control room. And you have those three joysticks. You can twist them right and left, bring them forward and backward. That's for the guide catheter. That's for the wire. That's for the device. And then you have the robotic arm. It has multiple ports. Every port it has would fit in the microwire, the device, the catheter. And then it is really user-friendly. So on every step, the screen will tell you what's the next step. So it's user-friendly, and the learning curve is really short. And there have been some papers about that. Gavin Britz in Houston has wrote a lot, but in animal models, in porcine models, he's used that. And this is a little bit, sorry. This is showing how we prep the robot. So there's the cassette, which is placed here, and this is changed for every patient. And then everything is draped, and then we're gonna bring it all the way to the patient. And then there is a plastic tubing that you're gonna pull, and you're gonna hook to the sheath, and this will prevent any catheters from herniating out. So here is the plastic tubing. That's a Snuffbox procedure. That's the sheath. I hook it to the sheath, and then the catheter, guide catheter TUI, it has a special place here. And then this is where we put our microwires and devices, and this is our TUI. It locks there. This is the first transradial carotid stent done.
You can advance and retract, and you can do that all at the same time.
So as you see here, I'm manipulating all the devices. I'm manipulating outside, and this is the robot that I'm moving. Here it is. It was a left-sided, you see here. That's Dr. Jumakaris, my partner. And I'm bringing up the protection device. Then bringing up the balloon, doing the balloon angioplasty, all from the control room, and then placing the stent. And that's the team. We were, and this is the right-sided carotid. Again, transradial, look at this carotid disease. It's really at long extent and high. So here we're in the room, they are feeding the wire, and then I'll take over here. And now I'm manipulating the wire to cross the lesion. And again, manipulating the wire is you have more finesse with manipulating the wire and more delicate manipulation than with your hand. Here I'm bringing up the spider, the protection device. This is what's happening in the room in this little corner. And then I'm gonna bring up the balloon. That's the balloon. You're gonna see the balloon angioplasty in a little bit. Then I'm gonna pull back the balloon, bring up the stent robotically. That's the stent. And then here it is, the final result.
I'm on fluoro.
This is what's happening in the room. While I'm working there, you see catheters going in and out alone from the robot. Another case of a left-sided carotid. So here I'm bringing my ballast all the way up. That's a nasty carotid lesion. Now I'm bringing my protection device. I'm advancing it robotically. Then balloon angioplasty, and that's the final result. We were in the newspaper, in the on TV, everywhere with the team. And this was the first we published our series of feasibility and proof of principle for diagnostic and carotid artery stents. This is the 10 first patients that we did. This is another paper that's gonna come out in Journal of Neurosurgery soon. It got accepted, where we did a comparison between robotic assisted and manual carotid stenting. And as you see here, the main goal was to make sure that everything is the same. Not inferior. There's no statistical difference in the fluoroscopy time, contrast dose, radiation exposure. The procedure time is a little bit longer because this is a new technique and there's a learning curve, but there's no increase in contrast, fluoroscopy time, or radiation time, which is the most important. And we are training the next generation fellows. They are all excited with using the robot. And then we were doing this until this little creature invaded our world. And we started doing crazy things after that, like
finally we go into the
doing
neurosurgery
TikTok.
department at Jefferson Hospital's vascular division. Check out this TikTok of Dr. Pascal Jabbour and his team.
I'm good. I'm good.
That's Dr. Jabbour in the hood in the back left corner.
In the hood, she meant in this hood, in the paper. So Kimon, do I have 5 minutes or you want me to wrap up?
You absolutely do.
Okay. All right. And then we start seeing weird things. You know, you go to the supermarket, you see those creatures, and then I don't know how protect yourself with mask got translated to buy all the toilet paper that you can ever see in a supermarket. And then we start seeing stuff like this. This is in my hospital. There's a bucket where they ask you to remove your mask because we're re-sterilizing masks and we're reusing masks. So
by the way, Pascal, you know, there was an article, I think, in some of the JAMA papers, I mean, JAMA journals yesterday about the fact that even the slightest amount of re-sterilization of an N95 destroys the integrity of the mask.
Yeah, I know.
So you should re-sterilize.
Yeah. So again, look at the contrast. I just show you one of the greatest innovations in endovascular. I just showed you a neuroendovascular robot. There are only 3 places in the country that has it for neuroendovascular. And here it is. I'm showing you that we're re-sterilizing the mask with the economical crisis that happened. And like little things start making us happy. What do you think there is in this bag? It's nothing other than an N95, which is really precious, which I need to use it for 7 days. And if I lose it, they can get me another one. And then we started doing more and more strokes that are COVID positive. Again, I mean, in your center, you have a lot of those, but those are different kind of patients. Those are patients with no risk factors, with high burden of clot. This patient had an MCA and an ACA at the same time. And then we have our, this paper is gonna come out soon next week, where this was our initial paper, 14 patients, 31.5% of the strokes admitted between March 20th and April 10th was COVID positive. They were 42% less than 55 years old, 42.8% did not have any risk factors for stroke. And despite the fact that we got TK2B and 3 in all the patients, mortality was high, 42.8%. Other interesting findings, 50% of them, stroke was the first symptom of COVID. Then after that, we had an international collaboration of patients where it confirmed the same thing. So again, now with every procedure, it's a big ritual of gearing up and putting the paper, which is, as you can imagine, taking much longer to do cases. And this is the team going to do a stroke in style. Well, as you see that the FDA gave an emergency use authorization for remdesivir, knowing that the difference in results weren't so big, but they gave that. Maybe it's time in the time of pandemic to have the FDA take a better look at the endovascular robotic. Maybe this is an answer for the distancing and for protecting the team. As you know, right now, we're only allowed in the US to do carotid stents, not intracranial or strokes, but in Canada, they've done aneurysms. Technically, it is feasible, but because it's not FDA approved, we cannot do it. So similar to the expedited approval of certain COVID medication, I think this is an option to protect the team. Maybe we need a quick approval of the stroke. So I think the CorePath system was easy to set up, was user-friendly for diagnostic and carotid stents. The advantage of the system is to eliminate the physician radiation exposure, and as well as reduction of orthopedic injury, more ergonomic because we don't have to wear lead. more accurate microwire and microcatheter manipulation, and the rapid improvement in technological engineering may potentially enable performing remote strokes. There are still some challenges for remote stroke, but imagine if a patient can get to downtown in a timely manner, or if the patient gets to downtown, it's gonna be too late. Maybe he'd better serve getting the procedure remotely with all the risks that we know, but maybe we're giving him a better chance. Again, technology is a double-edged sword.
Emma. Emma.
Every day it's getting on my nerves. Oh, I'm
Emma.
Thank you.
Thank you, Pascal. That was a great lecture. You know, really innovative stuff. And I hope they, I don't know what the process is, but I really hope they allow intracranial use of the device. I mean, we have been definitely, we've been very interested, like you are, in this device. I mean, you know, not only protecting the team, but then, you know, you have radiation exposure, a lot of other things, not just the COVID stuff. So definitely, I think that's where the future is headed. Again, we're just a tiny bit over, just 3 minutes. So I think we did fantastic on time. I want to thank Dr. Jabbour for donating his time to us. Any of you that need CMEs, you'll get an email tomorrow with details about how to claim those CMEs. And we're offering 2 hours of CMEs for this webinar. Thanks everybody for your participation and your interest. Again, thank you, Dr. Jabbour. And we're looking forward to seeing everybody in one of our future webinars. Thank you.
Thank you, everyone. It was a pleasure.
Take care. Bye-bye.